Hello, and welcome to our scholarly project presentation. Our topic of presentation is reducing telemetry use on family health service, a quality improvement project. I am Cian Chung. I'm a third year family medicine resident.
Hello, and I am Judy Zhang, a second year resident at Crozier Keystone Family Medicine Residency Program.
Disclosures: we have no conflict of interest to report. Telemetry, also known as continuous cardiac monitoring, was originally developed for the monitoring of cardiac arrhythmias. Since then, the use of telemetry monitoring has increased and its indications for use has significantly expanded. Currently, telemetry is overused in many hospitals. In 2013, the Society of Hospital Medicine identified telemetry overutilization as a significant source of healthcare system waste. As part of the Choosing Wisely campaign, a statement was made by the Society of Hospital Medicine to discourage telemetry usage outside of the ICU without a discontinuation protocol. DCMH is a community hospital with 168 beds. We have a limit of only 45 non-ICU telemetry beds in this hospital.
Our limited telemetry bed increases the need for appropriate use of telemetry monitoring to reduce alarm fatigue and to decrease interruptions and delays in patient care.
The overuse of telemetry also contributes to emergency room overboarding and significant delays in patient care. A telemetry utilization team consists of cardiologists, nurse supervisors, and hospitalists. The purpose of this team is to help decrease system-wide inappropriate use of telemetry. We were informed by the telemetry utilization team that about 50% of family health service patients are on telemetry, which was far greater than the national average of 25%. At our hospital, as part of the mission order set, it is required to select general care, which stands for non-telemetry bed, or monitored care, which means that they would be placed on the telemetry unit. However, there's no system in place for discontinuation of telemetry orders, and this leads to a prolonged stay for patients on the telemetry floor. This quality improvement project was devised to help educate the family medicine residency about indications for telemetry use and to assist in reducing the telemetry usage numbers. Approval for the study was received by our IRB team at Crozier Keystone Health System. Need for patient consent was waived. Indications for telemetry use proposed by the American Heart Association in 2017 was reviewed, and a quick reference list of indications was devised.
Please see the handout for the list of indications for telemetry that we are using to educate our inpatient resident team. We educate our residents on the specific indications for telemetry and on the recommended durations they should stay on cardiac telemetry.
Cardiac telemetry orders were then promptly discontinued when not supported by the AHA guidelines. Prior to the telemetry discontinuation, approval was given by the attending physician to ensure patient safety. Interventions we used to reduce telemetry utilization included a 15-minute presentation on the correct indications. A printout for quick reference of these indications were placed in the resident room. There are also daily telemetry rounds prior to morning rounds to review each patient on telemetry and whether these patients need to be on telemetry. These interventions were carried out during the dates of January 27, 2020 to February 23, 2020. A chart review was performed to identify indications for telemetry usage. This was compared to patients admitted to the service on January 28, 2019 to February 24, 2019. This is the pre-intervention arm.
The dates January 28, 2019 to February 24, 2019 were selected for comparison due to its similarities to the intervention arm in terms of team composition and rotation block of the academic year.
Patients that were admitted to the intensive care unit during any time of their hospitalization was excluded from our study. This was to account for our hospital policy that any patients that get downgraded from the ICU are to be placed on telemetry. Percentage of patients on telemetry during these study dates were provided by the telemetry utilization team.
For results, so these are our patient demographics. The dates January 28, 2019 and February 24, 2019, and January 27, 2020 to February 23, 2020. In the pre-intervention group, we had a total of 77 patients admitted to our service. 7 of these patients required ICU level of care during the hospitalization. 59 patients required non-ICU telemetry monitoring during their hospital stay. In the intervention arm, a total of 71 patients were admitted to our service. 13 of these patients required ICU level of care during their hospitalization. 57 patients required non-ICU telemetry monitoring during the hospital stay. The total number of patients requiring cardiac monitoring were similar in both arms, and patients in both arms were similar in age, gender, and ethnicity. Here we have a graphic representation of our telemetry utilization. I would like to direct your attention specifically to these two dates, February 2019 and February of 2020. In February 2019, our telemetry utilization team reported 104 total days on monitor out of a total 191 patient days. This is calculated to be about 54.4%. In February 2020, our team reported 83 total days on monitor out of a total 229 patient days, which is about 36.2%. Comparing to our pre-intervention and intervention arm, there was a significant reduction of telemetry utilization from 54.4% to 36.2%. This is with a p-value of less than 0.01. Chart review of both arms showed that there were patients placed on telemetry for indications not endorsed by American Heart Association. The most common indication for telemetry use in both groups was for patients presenting with chest pain and admitted for rule out of acute coronary artery disease. Indications for telemetry use in both groups were similar, except for chronic atrial fibrillation. For discussion, there was significant reduction in telemetry usage pre and post intervention from 54.4% to 36.2%. The study showed that in educational intervention and daily review of telemetry orders led to significant improvement in appropriate telemetry utilization. The study shows that an inexpensive education intervention may lead to a reduction in health cost and waste of healthcare systems. We believe that this project's key success factor include increased awareness of telemetry ordered and addressing telemetry orders on a daily basis. A significant contribution to high telemetry numbers on service was due to patients staying on telemetry for prolonged periods after initial admission orders. Limitations of this study include educating family medicine residents, and the study was also performed at a single health facility. This study may not be generalized to other institutions or other resident-ran inpatient teams. Educational intervention needs to be maintained and repeated regularly, or the effects will taper over time. In the future, our health system will be implementing a new electronic medical record system. Many previous studies have found success in incorporating heart stops in the electronic medical record system and auto discontinuation orders. There are patients from both groups put on monitored beds for indications not endorsed by American Heart Association. The indications are listed here and include respiratory distress, secondary to pneumonia, chronic obstructive pulmonary disease, and asthma, altered mental status, including seizure and hepatic encephalopathy, anemia that was asymptomatic with no documentation of tachycardia, systemic inflammatory response syndrome with no documentation of tachycardia, and GI distress. Patients were often placed on telemetry due to physicians being unsure about the patient's condition and stability. Of note, one big change that we saw between the pre-intervention arm and intervention arm was ordering of telemetry monitoring for chronic atrial fibrillation patients. One significant difference that we saw between the pre-intervention arm and intervention arm was ordering of telemetry monitoring for chronic atrial fibrillation patients. Per American Heart Association, if patients with chronic atrial fibrillation were admitted for reasons other than arrhythmia or rate control, and that patients were hemodynamically stable, that there was no benefits for continuous cardiac monitoring. As a result of this study, there were no witnessed or documented adverse effects. In conclusion, our goal to reduce telemetry overutilization is achievable. The study demonstrated efficacy in educating the inpatient family medicine team about 2017 AHA guidelines for cardiac monitoring. We believe to reduce telemetry usage requires a multi-pronged approach of integrating education intervention with electronic medical record system. Here are our references for our project.